Okay, I'm going to show you how to wrap a hand here, and we're going to start distal to proximal, so hold your hand up like this. I'm not going to have this open because it goes into his fingers and it starts to get real dirty like that. So what we're going to do is we're going to fold it over and do a circular wrap like that with it folded to stabilize it. And then you can come around, open it like that, and do your kind of your figure eight right here. Now if you need to come back up to the hand, you can once again fold it over. It's folded in half, and then bring it up again like this. So it's really stable right there. Now depending on where the problem is, if you need to keep going back and forth you can, otherwise you can come up and stabilize the wrist a little bit more with your reverse spiral. Remember, always start distal and go to proximal because you want to push the blood towards the heart. So that's a little figure eight around the hand with a reverse spiral coming up like that, and that's what it looks like. Okay, we are wrapping a stump or an amputation right here. So what we do most of the time, you start distally and go proximal, but you can't do that because there's nothing down here. So what you're going to want to do is do a circular wrap up here. This is just illustrating the stump, okay? It's obvious that it isn't, but you want to go around once, and then you want to come down like you're doing a reverse spiral, and then come back up, and you want to get it down over this area as quickly as possible. So the next one comes back up like that. The next one should go down over this area. And if you look at that pattern, it looks the same as the reverse spiral. And of course, when you're wrapping this in the hospital, you'll be wrapping it with a longer bandage than this one. So you have a little more cushion down here. That's what it looks like, wrapping a stump. Okay, I'm going to show you how to give a basic injection, an IM injection, and you have to have the appropriate size needle. And IM injections usually come maybe in a 2 to 5 cc volume. So this is a 3 cc volume right here. And actually 3 cc's is the maximum med dose that you can put into a patient into one area. Otherwise it starts leaking out into other areas. But let's say we're going to give our patient 1 cc or 1 milliliter of Demerol or narcotic. So what we're going to do is pull the plunger back to the 1, and the top line is on the 1 on this needle here. So the top line, not the point of the plunger, but the top line is right on the 1. So you've got your area there. Now you're going to get your vial, you're going to snap it open, and it's sterile there. Now if it's been open once, you need to clean it with alcohol on the top, on the lid, but if it hasn't been open, don't clean the lid. And then when you take the lid off of your needle, you want to pull it straight out like this, and just putting it back on again, you want to be very careful when you put it back on because you don't want to stick yourself. Sometimes people will put it on at a bit of an angle or on the edge of a table like this, but you've got to be very careful not to hit the table, and you want to make sure that you never ever recap after you've stuck a patient. Okay, so at this point, this is a vial, it's a closed container, and you have to replace whatever comes out of this with something else, which we're going to replace it with air because it increases or decreases the resistance in this if it isn't an equal pressure. So you're going to put your 1 milliliter of air into here. So push it in the middle, push it in, then turn it over where the label is facing where you can see this part, and you're going to pull up your 1 milliliter of fluid. Now you see I've pulled a little bit beyond 1 milliliter so I can push a little bit back in. And I see that I have a little bit of a bubble down here no matter what I do. So I'm going to pull out just a tiny bit more than 1. Pull it out. And then at this point I'm going to flick it. And I don't know if you saw that bubble rise up to the top. And then pull down just a little bit to make sure that it's at the top. And then you push it. And you can push the little bit of the excess into the sink, and then I have it right there at 1 now because I just pulled a little bit extra out. And see that little bubble that was a fluid that was at the top of the syringe? That just showed that the needle is full of fluid. It's ready to go. So at this point, you need to open your alcohol swab in the middle, get it ready to go, and come over to your patient. Usually come over with everything ready to go. Tell them, of course, what you're doing, and you want to find your landmark. This is your vastus lateralis, so you're going to go under your greater trochanter, above your patella, on the imaginary G line, and 1.5 inches up. So you're going to take your alcohol swab and swab from inner to outer. Alcohol works with friction, so swab it good. Then you can hold it in those 2 fingers like that. Pull it off like this, set it over to the side, and then stabilize. Push down if you're doing intramuscular and pinch up if you're doing subcutaneous. But you want to take it and just put it in like a dart, straight in, 90-degree angle, like that. And then at this point, you can take with your thumb and pull back just a little bit. And if you look in the end of this right here, I'm trying to show you right here where you can see a little bubble form. If you were in a blood vein, you would see blood, but this is just like a clear little bubble there. And we know that we're not in the blood vein, so at this point we can put our thumb on the end, push the medicine in, get your alcohol swab. And what I usually like to do if I end up using this instead of a cotton ball is I usually, after I do it the first time, I'll turn it inside out so you're using a completely clean area, and just have it ready right there so when you pull it out you counter pressure kind of over that area so the fluid doesn't follow out and it doesn't bleed as much. And then this goes directly into the sharps container without recapping it at all. I'm going to show you some different types and sizes of needles, and this is your biggest one. This is for your IM injection, and it usually comes in a syringe volume of about 2 to 5 cc's, the normal being 3 cc's. Now if you're giving 3 cc's of medication, you may want to bump your syringe size up to 5 cc's so you'll have room to aspirate. But it's usually 2 to 5 cc's. Your maximum med dose for an IM injection would be 3 cc's because you don't want to put too much into one area. Your needle length to get it down into the intramuscular area is usually 1 to 1.5. So if you have a small patient, use a 1-inch needle. If you have a larger patient, use a 1.5. And sometimes you can find a 2-inch needle if you have a pretty heavy set patient, because you want to get it down into the intramuscular area. To give an IM injection, you want to put it in the patient at 90 degrees straight down. Subcutaneous is a little bit smaller, and you can use a syringe this size or a smaller syringe depending on how much you're putting in. The needle length is obviously smaller because it's more superficial, and the syringe volume is 1, 2, or 3 cc's usually. Your maximum med dose for sub-Q is 1.5 cc, exactly half of the maximum med dose for the IM injection. Intradermal is next, and that's what you would use to give a TB injection, and that's about that size right there. It's the same size basically as your insulin is right here, but there's a few differences. Your insulin usually comes with a brightly colored orange top. It comes in units instead of cc's, and usually the needle is non-detachable. So that's the difference. So you always give insulin in an insulin syringe, and intradermal in an intradermal syringe. And the maximum med dose for intradermal is 0.2, which isn't very much.